My patient, 32-year-old gentleman from Alwar, farmer by occupation, came with chief complaints of pain abdomen since 2 months and yellowish discoloration of eyes and high-colored urine since 25 days. Coming to history of presenting illness, patient has pain in upper abdomen since 2 months, which was insidious in onset, gradually progressive, intermittent in nature. He had 2 to 3 episodes per day, which was dull aching type, mild to moderate in intensity. The pain was radiating to back and pain relieved with oral medications. It was not related to food intake or postural change. Patient didn't need any hospital admissions for the pain. History of presenting illness. Patient noticed yellowish discoloration of eyes. And since 25 days. Jaundice is insidious in onset, progressive in nature. There were no waking and waning episodes. And he gives history of passing clay-colored stools, not preceded by prodromal symptoms, not associated with pruritus. Patient also gives history of loss of appetite and since 1 month, and history of he used to take around 4 chapatis per day, but now he is able to take only a single chapati, and history of loss of weight since 1 year, which is not quantifiable. He is telling that he has loosening of his clothes, sir. And patient has no history of repeated episodes of pain in upper abdomen. There is no history of fever, no history of vomiting, no history of melena or hematemesis, no history of bleeding per rectum, no history of abdominal distension, no history of shortness of breath, no history of headache, seizures or blackouts, no history of back pain or bony pain, sir. Past history, he is a known case of diabetes since 1 year, not on regular medication. He gives no history of hypertension, tuberculosis or asthma. Patient did not undergo any surgeries, and there is no history of repeated episodes of pain in right hypochondrium and no history of repeated episodes of pain in upper abdomen, sir. Personal history, patient consumes mixed diet. He has disturbed sleep since 2 months and bladder habits are regular. He is a known BD smoker, consumes around 3 BD per day since 10 years, and he is known alcoholic since 10 years, consumes 100 ml of alcohol at around 1 time a week, sir. Family history, there is no significant family history. To summarize, 32-year-old gentleman, known smoker and alcoholic with recent onset diabetes, with painful progressive jaundice since 2 months, with history of loss of weight and loss of appetite, sir.
Go back to your first slide, the presenting complaints.
Pain abdomen since last 2 months.
Here you said pain abdomen. It's always better to mention here only the side. So you could have said whether it is central upper abdomen, right upper abdomen. That to some extent may suggest the possible organ of disease. Okay?
Yes, sir.
Because if you have epigastric pain, you will think more in terms of pancreas. If you have right upper abdominal pain, you will think more in terms of gallbladder. So if the patient is pointing out the site of pain, it is always better to mention it here also. Next. So what do you think this pain is?
Sir, pain is characteristically pancreatic pain, sir. Typically dull aching, radiating to back. So most probably
see the importance of the site of pain, because here you have said upper abdominal pain. You are thinking of pancreatic pain. If you had said right upper abdominal pain, you probably would have thought of gallbladder or liver, isn't it?
Yes, sir.
Next. So you said that he has pain for 2 months, but you are saying that he has weight loss for last 1 year.
Yes,
how do you correlate?
Sir, actually patient was diagnosed as diabetes 1 year back, and it was associated with gradual loss of weight since he was diagnosed, sir. So maybe the symptoms have occurred earlier, and now the patient has presented to us with chief complaints now. But the disease
most probably this weight loss is not because of the current problem. It is probably related to his diabetic status. That is the possible explanation. So you have mentioned this twice, no history of repeated episodes of upper abdominal pain in the past, and then you mentioned it in the past history also.
Yes, sir. Because here I also want to know about last 6 months history, sir. And in past history, I was asking him for episodes since childhood, sir. So I have mentioned it twice.
Yeah, but generally the present history is limited to whatever is the duration of symptoms. So here the duration of symptom is 2 months.
Yes,
So
sir.
you can't say that there is no history of upper abdominal pain during the current illness. His presentation is with pain. So this should preferably go to the past history. No need to mention it here because there is a contradiction there.
Yes, sir. Okay, sir.
Next. Yeah. So here it is fine that there is no history of biliary colic or there is no history of pancreatic pain.
Yes, sir.
Okay. Next. So what do you mean by one time in a week? Does it help me to know how much alcohol he is taking? You haven't mentioned the volume. You haven't mentioned what preparation of alcohol he takes. Even if you yourself as a teetotaler, you need to know what are the different types of alcohol, how much absolute alcohol each 100 ml contains. How much does beer contain?
5%, sir. 5%.
Yeah, so if you consume a Western brand of beer, it is about 4 to 6. Check, I'm also not sure, but the Indian brands usually have, I think, 8%. Am I right? Yes, yes. The boys here say I'm right. On the other hand, if you go to whiskey, 40%, 40. And
44.
yeah, so you have to mention what preparation of alcohol, how much volume, and how frequently. And then you calculate the absolute amount of alcohol which he is taking. There are standard. The other day we discussed. I don't remember what was told. I think for men it is 30. So there are different amounts which are mentioned, and he should be taking most days of the week and for a reasonably long time. Check on that because with this one, I can't say whether he is an alcoholic or not, and anybody who takes alcohol is not an alcoholic.
Yes, sir.
There is a medical definition of alcoholic. So you can't label everyone who's taking alcohol as an alcoholic. Okay?
Yes, sir.
Yes. Next.
May I interrupt, sir?
Yes, Rajan.
Yeah, Sindhura, what are the units of alcohol? Alcohol is measured in units. For each drink, it's a separate unit. You should know it for beer, wine, and whiskey. Whiskey is 130 ml is considered 1 unit.
By volume.
Wine, 1 glass is considered 1 unit. And beer, 1 mug is considered 1 unit. That's 250 ml is considered 1 unit.
Yes, sir.
So if you remember that, you can tell number of units of alcohol consumed per day, per week, for how many years. Just like back years, you have to mention units of alcohol consumed.
Yes, sir.
Up to 2 to 3 units of alcohol per week. 2 units of alcohol per week are considered normal usage, and they do not contribute to morbidity. More than 2 units, 3 or more units has been associated with disease.
Yes, sir.
So you should know that.
So whenever you mention the history of alcohol intake, you have to mention the type, the volume, and the frequency and the duration. Okay? Yes.
Yes.
Next. So here again, I don't know whether he qualifies to be called an alcoholic. Okay?
Yes, sir.
Yes. So what is your interpretation of this history?
Sir, my patient is with extrahepatic biliary obstruction, sir.
Mhm.
With being a smoker and an with recent onset of diabetes, I would like to give a DD, sir.
Mhm.
My first diagnosis would be carcinoma of head of pancreas, sir. Because and followed by carcinoma of gallbladder, periampullary cancer, hilar. I would also like to keep benign causes, cholelithiasis and chronic pancreatitis also, sir.
So he is only 32-year-old.
Yes, sir.
Would you like to make a first diagnosis of malignancy?
There is a few points in favor of malignancy, sir, like recent onset diabetes, loss of weight, loss of appetite. So I would like to consider this first, but I would also like to consider the benign causes, sir.
Which of the two benign causes which you have mentioned, which is more likely?
Choledocholithiasis is more likely, sir.
Why?
Because the patient presented with jaundice, sir.
Is the pain like biliary
But
colic?
yes, sir. There are negative points for choledocholithiasis, like the pain is mainly pancreatic type, and points in for chronic pancreatitis are patient has pain, but it should be associated with biliary stricture for jaundice, sir.
Can you consider
Feeling the knee,
Meiji
yes.
syndrome?
Sir,
Can you consider
Miritzi.
Meiji syndrome?
Miritzi syndrome, Dr. Desai
Yes,
asking,
sir.
would you like to
I would
consider Miritzi syndrome?
Yes, sir. I would also consider Mirzi's syndrome.
Yeah, and pain of choledocholithiasis is like pancreatic pain. It is in the central back, and it radiates to the central back, and it is upper abdominal pain, which you have said. So choledocholithiasis is also possible. One thing against a young man having choledocholithiasis is choledocholithiasis becomes more common with age. So an elderly person is just as likely to have choledocholithiasis as he is likely to have malignancy. But a young person, unless he has clear-cut biliary history, cannot make a diagnosis of choledocholithiasis. So it is common. In the north, gallbladder stone disease is common. Gallbladder palpability, you can say it is an exception to Courvoisier's law. So that is the thing. So you can still defend that diagnosis.
So you said that chronic pancreatitis pain, you thought it is like pancreatic pain, and you said that jaundice will occur in chronic pancreatitis if there is a biliary stricture formation. But
Yes,
based on history, you cannot delineate, you cannot differentiate that
Yes, sir.
whether there is biliary stricture or not. So can patients with chronic pancreatitis present with jaundice?
Only 10 to 15% patients present with such presentation when there is ampullary stricture.
So it is possible to have
Yes.
in the negative history, did you mention about any symptoms of steatorrhea? So since you are going to consider, or you knew that you are going to mention a differential diagnosis of chronic pancreatitis, you should have asked the history of steatorrhea. If it
Yes.
is there, it may have supported your diagnosis of chronic pancreatitis. Its absence doesn't rule it out, but if it is there, it would support it, isn't it?
Yes, sir.
Now, in the list of malignant causes of surgical obstructive jaundice, you have mentioned all four.
Yes, sir.
Do you think it is possible that this is periampullary or hilar cholangiocarcinoma?
Usual presentations are painless progressive jaundice in periampullary and hilar cholangiocarcinoma, sir. But few cases present also with pain. So I would like to consider them as a DD. Sir.
What causes pain in a periampullary carcinoma? What kind of pain it is?
Usually, the block at the level of ampulla causes pancreatic pain due to accumulation of all the secretions, sir. One. And inflammation. Both cause pain in periampullary cancer.
So if it is a ampullary or papillary variant of periampullary cancer where there is obstruction of the pancreatic duct also, when the ducts get dilated, it can produce symptoms like any other ductal obstruction and dilatation, what we commonly see in chronic pancreatitis. Also, rarely a periampullary tumor can precipitate an episode of acute pancreatitis. So you can have acute pancreatitis. In fact, if you see acute pancreatitis in an elderly gentleman who has no gallstones, who doesn't take alcohol, you should seriously consider a pancreatic tumor as a cause of acute pancreatitis. And third is that an over-distended gallbladder will give rise to dull, diffuse, continuous discomfort like pain in the right upper abdomen. Hilar cholangiocarcinoma is the least likely to be associated with the pain because usually these are small tumors. They don't infiltrate any adjacent organs to cause pain. Okay.
Yes.
What is against a diagnosis of choledocholithiasis here? One, we said that the pain doesn't look like biliary colic. Although
Yes.
Dr. Desai did correct you that pain of choledocholithiasis can be epigastric and may mimic pancreatic pain. What else? What is the typical presentation of choledocholithiasis?
Sir, patient would have had prior episodes of cholecystitis and gallstone disease before. And
May or may not.
mm,
Yes. What about jaundice? What is typical of jaundice in choledocholitis? It is intermittent jaundice, isn't it?
Yes, sir. Yes, sir.
Here, the patient has progressive jaundice for 25 days, which is little unusual for choledocholitis. What are the conditions, what are the situations where choledocholitis can give rise to progressive jaundice for 25 days?
A large stone obstructing the ampulla completely would give rise to a progressive jaundice, sir. But if it is a small stone and first presentation, it would be usually intermittent jaundice.
So an impacted stone at the lower end, and the point which Dr. Desai asked you, a Mirizzi syndrome. Mirizzi also is a stone. Actually, the stone is in the gallbladder, but since there is a fistula now, it is lying in the CBD. It is in the mid CBD, and it is impacted there. So that also can cause progressive jaundice. So these are two exceptions to the usual presentation of choledocholitis, which is with intermittent jaundice. One is impacted stone at the lower end, and second is a Mirizzi syndrome. Okay, let's proceed.
Coming to general physical examination, a young male.
Sorry, one more point. So he's 32-year-old man, and you are thinking of carcinoma of the head of the pancreas. What else you should have mentioned in more details to us?
I mentioned about bleeding PR, sir, because I suspected about polyposis syndrome. So I have asked him, and he told that he has no bleeding per rectum.
And
I
although FAP is not associated with carcinoma head of the pancreas, it is associated with papillary tumors.
HNPCC and Jaggers, sir. Yes, sir. And I also asked about childhood episodes, pain abdomen since childhood, which is hereditary chronic pancreatitis, which has continuous chronic pancreatitis episodes, which were not present in our patient.
Yes. What else you should think of when you see a young man with a suspected carcinoma head of the pancreas? One is polyposis, one is hereditary pancreatitis, and
family history also I have asked, sir.
Family. So your family history should be in more detail rather than saying no family history of cancer. It would be better to mention that there is no family history of any cancer in at least the first and maybe second degree relatives, which is very unlikely. I don't think you will find any individual today who doesn't have a family history of cancer in any of the first or second degree relatives.
Yes.
So family history has to be in more details than what you just mentioned, that there is no family history. Okay?
Yes, sir.
Yes.
Coming to general physical examination, our patient is a young male, averagely built and nourished, with height of 170 centimeter, weight of 59 kg, with BMI of 20.2 kg per meter square. His ECOG1, he's conscious, cooperative, well-oriented to time, place, and person, lying comfortably on bed. His pulse rate is 84 beats per minute. Blood pressure is 110 by 80 millimeters of mercury. Respiratory rate is 18 per minute, and saturation of 99% at room air. On examination, patient has icterus. There is no pallor, no cyanosis, no clubbing, no pedal edema. There is no left supraclavicular lymphadenopathy, no stretch marks, no scratch marks, and there are no signs of liver failure. On inspection, abdomen is flat, umbilicus is central in position and inverted. All quadrants move equally during respiration. There were no mass, sinuses, engorged veins, pulsations, and peristalsis seen. Hernial sites appear to be normal. No renal angle fullness. External genitalia are normal. Coming to palpation, abdomen is soft and there is no local rise of temperature. There is no tenderness. Gallbladder is palpable. There were no other mass or organ palpable. Hernial orifices are normal. External genitalia are normal. Coming to percussion, liver dullness starts at 5th intercostal space, liver span of 12 centimeter in mid-clavicular line. Dull note over gallbladder, which is continuous with liver dullness noted, and rest of the abdomen is resonant to percuss. On auscultation, normal bowel sounds are heard. Per rectal examination, sphincter tone is normal, mucosa is normal, finger gloves stained with ecolic stool. There is no blood in stool, no mass felt. Examination of respiratory system. Respiratory system is normal. Examination of serious CNS are normal, sir. To summarize, 32-year-old gentleman with ECOG1, non-smoker and alcoholic, with recent onset diabetes, with painful progressive jaundice, with loss of weight and loss of appetite with palpable gallbladder and ecolic stool on per rectal examination.
So this has been pointed out earlier also, I think by Dr. Desai, that whenever you say patient has icterus, it is always good. Some examiners expect you to make a subjective assessment, whether it is mild icterus or deep icterus. So that should be mentioned. Palpation, go back to palpation. Is it enough to say gallbladder is palpable? That's a complete description.
I would like to say solitary.
Again, many examiners would insist that your description, your history and examination should be as was taught in our MBBS days. So gallbladder is palpable is an interpretation. That is not a finding. Some examiners would say, no, you should describe it as that there is a lump palpable in the right upper abdomen and then go on to describe it. So this is not good enough. You have to describe the features. What all would you like to tell us?
So there is a solitary palpable mass of size 8 cross 6 centimeter, globular in shape. Surface over the swelling is smooth and it is soft in consistency. The swelling is moving with respiration and all lower, lateral and lower borders are palpable and upper border couldn't be delineated, sir.
Anything that you have missed?
Movement, sir. Only side-to-side mobility is present. No
So all this should be mentioned. Why did you not mention in the first instance? You have to mention everything. Okay. Go to the per rectal examination. What do you mean by no mass felt? Are you looking for a mass in the rectum?
Sir, I'm looking for metastasis, sir. Bloomer shell.
So which mass are you looking for?
Nodular metastasis in.
So you have to say no extra rectal or rectovesical pouch mass palpable. Otherwise, no mass palpable means mass in the rectum. The description has to be correct. And summary, you should always add whenever you are considering a possible differential diagnosis of malignancy, no clinical evidence of metastasis. Fine. So how does this palpable gallbladder, what do you think this palpable gallbladder is?
Sir, it is a.
Speak a little louder.
Yes, sir. I would suspect that the obstruction is below the cystic duct origin, sir, mostly in the periampullary region. So that.
Why is this not CHGB? You said gallbladder is palpable.
Yes, sir. It can be a carcinoma of gallbladder when there is a mass at the neck of the gallbladder, sir. I've kept my diagnosis as a. I would also like to consider it as my DD, sir.
So your clinical examination should be able to differentiate between a distended gallbladder, which is taking the shape of the gallbladder. It is soft to firm in consistency. It moves with respiration and has a side-to-side mobility, has a smooth surface. Versus a GB lump, which may or may not be taking the shape of gallbladder, which is usually firm to hard. It will also move with respiration, but it will not have side-to-side mobility, and it may have a nodular surface. So if you have a distended gallbladder, it means that either it is a mucocele, like in gallstone disease, or if you are thinking of malignant surgical obstructive jaundice, there is a block at the lower end, which could be periampullary or a carcinoma head pancreas, or there is a block at the cystic duct, which means either a GBC neck or a mid-CVD cholangiocarcinoma. All these can give rise to a distended gallbladder. On the other hand, if you have a GB lump palpable, then it is a carcinoma gallbladder. If GB is not palpable, it is more in favor of a hilar cholangiocarcinoma, because in hilar cholangiocarcinoma, GB will not be palpable unless it is extending to the mid CBD and causing a cystic duct block, and then you have a distended gallbladder which is full of mucus only, not bile. Okay, what will you do?
Sir, I would like to proceed with 2 sets of investigations, sir. First, to diagnose the disease and to know the general condition of the patient, sir.
So what will be the first investigation for diagnosis?
Sir, I would like to do an ultrasound, sir, which is an extension of general examination.
Let's see.
Ultrasound report given was liver was normal in size with intrahepatic biliary radical dilatation. CBD is dilated around 12 mm. Gallbladder wall thickness is normal, distended with no caliculi. Pancreas is normal in size and shape. MPD is normal. There are no ascites and no significant lymphadenopathy.
Anything more you would have wanted to know on ultrasound?
Yes, sir. This ultrasound report is inconclusive. I would like to know whether there is any filling defect in the CBD, and I would like to know the status of pancreas. Whether
They have mentioned pancreas normal and MPD normal. Are you happy with CBD dilated 12 mm, or you want to know something more?
no, sir. I would like to know the cutoff. Where is it? Which is not usually possible in ultrasound.
So on ultrasound in a patient with jaundice, the first thing is to confirm that this is obstructive jaundice, which is by seeing intrahepatic biliary radicals dilated. Except first 2 or 3 days when IHBR may not be dilated, after 2-3 days of jaundice, if there is no IHBRD, it is very, very unlikely that this is obstructive jaundice. The only condition where that can be there is a very diffuse kind of primary sclerosing cholangitis. But there also a careful, good ultrasound evaluation will show some ductal dilatation in between the strictures. Okay. So first is to confirm that it is obstructive jaundice. Second is to know the level of obstruction. So a good ultrasound report should say that yes, there is IHBRD, then they should say confluence is formed or not formed, because if IHBRD is there and confluence is not formed, it is hilar cholangiocarcinoma. Then they should say whether the common duct is dilated. They use the word CBD when they mean both CBD and CHD, but they should say till what level it is dilated. So if you have IHBRD, confluence is formed, and beyond that no duct is seen, still it is a hilar cholangiocarcinoma, but it is a type 1, which is not involving the confluence. If they say IHBRD, confluence is formed, and CHD or upper part of CBD is seen, then it is probably a mid CBD obstruction, the commonest cause of which will be a GBC neck or a mid CBD cholangiocarcinoma. If they say CBD is dilated till the lower end, they have to specifically mention that. That rules out hilar cholangiocarcinoma, that rules out CAGB, and that points towards a carcinoma head pancreas or a periampullary carcinoma. Now, how do you differentiate that? You look at the PD. If the PD is not dilated, but CBD is dilated till lower end, it is most probably a lower end cholangiocarcinoma. If both CBD is dilated and PD also is dilated, and the two dilated ducts are approximating each other with no mass seen on ultrasound, it is a periampullary carcinoma. If both ducts are dilated but they are not meeting each other or they are not approaching each other, and you see a mass in the head of the pancreas, it is a carcinoma head of the pancreas. So a good ultrasound can tell you what exactly is the level and what is the cause of obstruction. In addition, when you have a dilated duct, a sonologist can pick up a stone in the CBD. Sonologist can pick up a mass inside the CBD, which is suggestive of a cholangiocarcinoma. A good ultrasound can even pick up the thickening in the wall of the CBD, which again suggests a cholangiocarcinoma. So you have to know that all this is possible on ultrasound, and if any of this information is not there, you have to ask for it. When you have long-standing obstructive jaundice with repeated episodes of cholangitis, which may have caused secondary biliary cirrhosis, you have to look at the spleen and you have to look at the collaterals, whether the patient has developed any evidence of portal hypertension. And if you combine the ultrasound with Doppler, then you have to look at the vessels also. So based on this ultrasound, what is your diagnosis?
So this ultrasound is inconclusive, sir. I would like to further proceed for CT and...
No. What is your diagnosis on this ultrasound?
Most probably it is distal obstruction, sir, above the level of pancreatic duct origin, mid CBD obstruction, according to this ultrasound.
So this suggests a lower end CBD cholangiocarcinoma, isn't it? Not a ampullary or a head pancreas, because the PD is not dilated. You expect PD to be dilated in any ampullary tumor, in any pancreatic head cancer. Okay, what next?
Sir, I've got blood investigation, sir, to know whether it is obstructive jaundice or not, and complete blood picture, sir, to know the WBC counts, and his HB is 12, sir. Counts are not raised, and Platelets are 1,21,000. His bilirubin is raised, sir, 22, and direct bilirubin is 19.6 with raised alkaline phosphatase with normal PTINR, sir. Albumin is decreased, sir, 3.3. And I would like to, and I did get other investigations which were amylase and lipase, which were raised 7,000.
Why did you get amylase lipase done?
I had a doubt about chronic pancreatitis also, sir. So I got amylase and lipase done.
So in patients with chronic pancreatitis, you do amylase and lipase?
No, sir. I wanted to know whether a patient has acute on chronic pancreatitis picture or chronic pancreatitis picture. As so,
Was the clinical picture suggestive of an episode of acute pancreatitis?
No, sir. Not really.
No. So there is nothing to suspect acute pancreatitis. You would do amylase lipase in a patient with chronic pancreatitis only if you are suspecting an acute or chronic episode of acute of pancreatitis, which was not there in this case. So probably they were not required, although they are elevated. So most probably the patient had an episode, but clinically we didn't suspect that the patient is having acute pancreatitis.
Yes.
Yes.
And his CA99 values were more than 1,000. CEA was 7.7 and HbA1c was 10.2, sir.
Don't read the reports. Give your interpretation. What do you make out of this?
Sir, yes, sir. He has uncontrolled diabetes, sir. And my interpretation of all the diagnosis is he's in obstructive jaundice without any cholangitis. With
what about CA99? What do you make out of
diabetes, it? Sir, actually, CA99 is also raised in benign conditions, sir. And I would first like to, we should not consider this value and we first decompress the duct and then reassess and then consider that value. Although it is not prognostically significant, it can
Do you mean to say that if you put a stent, CA99 will not rise?
No, sir, but this value as such should not be considered as malignant.
More than 1,000 is significant. If it's in the hundreds, if it is less than 300, then it should not be considered significant. But a level of more than 1,000 is significant. Yes. Second thing, you said that you did not consider cholangitis. How do you account for the low platelet count?
Yes, sir. Low platelet counts.
Could it be early sepsis?
Yes, sir. It is a sign of early sepsis, sir.
Yeah, so you should consider it. How can you rule it out? When there's clear-cut platelet count is 1,20,000, which is very low, you have to consider it. And CA99 will rise in cholangitis, in which circumstance it can go up to 1,000 also.
Yes.
Does he have any fever?
No, sir. No episodes of fever.
No fever or tachycardia?
No, sir.
Oh.
Although I would like to slightly differ with Dr. Desai that see, no history of fever, counts are normal, the total leukocyte count, enzymes are not elevated, AST, ALT. Platelets in sepsis probably would fall much later. So I'm not sure whether I would say that there is cholangitis. But in response to CA99, you should have said that I would not like to get CA99 levels estimated when the patient is having deep jaundice. I would get them done because at this point, whether they are normal or high doesn't help me. And yes, Dr. Desai said more than 1,000, but somehow I remember anecdotal cases where even in benign conditions like chronic pancreatitis or obstructive jaundice, they were very, very high. So best is not to get them done so that you don't get confused. You should get them done only when you have relieved the biliary obstruction, if otherwise it is indicated. But yes, very high levels are significant, but anecdotally they may be present either in chronic pancreatitis or in cholangitis also. What next?
Sir, I would like to proceed with the CECT pancreatic protocol, sir.
Why not MRI?
Sir, I am suspecting CA head of pancreas, which is most clearly seen in pancreatic protocol. CT, sir. MRI is also helpful in hilar cholangiocarcinoma or CAGB cases, but as I'm suspecting it to be pancreas, I would like to go with pancreatic protocol.
Yeah, so I also used to say the same, that for upper obstruction like hilar cholangio, CAGB with jaundice, MR, and when we say MR, it is MR imaging, MR cholangiography and MR angiography is a better investigation because your primary area of interest is vascular and biliary anatomy. On the other hand, for lower obstruction like CA head pancreas and periampullary, CT probably is better because you are mainly looking at the vessels. But more and more radiologists now say that a good MR is as good as a CT scan. So I think you could say either, but I would accept that for pancreas or periampullary, most of us are still doing a CT rather than an MR imaging. Let's see. What do you mean by pancreatic protocol? How is it different from a contrast enhanced CT scan?
Yes, sir. Pancreatic protocol CT has 3 phases, sir. One plain to pancreatic parenchymal phase, which is around 35 to 40 seconds, and portal phase, which is around 60 seconds, sir. It is different from triple phase CT, which includes scout image followed by arterial, portal venous, and venous phase, sir, which is 15,
Is that the
60.
only? So 3 phases, but the 3 phases for liver and for pancreas are different. Okay. And
Yes.
any other difference between pancreatic protocol and a contrast enhanced CT? The technique?
1 mm cuts should be taken, sir.
The volume of contrast, the speed of injection of contrast.
100 to 120 ml of contrast should be injected, sir, at around 3 to 5 ml per second.
So it's a large volume of contrast injected at a rapid speed, which obviously cannot be done with a syringe. So you have to use a pump to ensure that. And then there is this early exposure for the pancreatic parenchyma, early arterial phase. Let's see.
This is a plain CT, sir. I would like to see the lower lobes of lung have no pleural effusion. Liver shows prominent biliovascular markings, and I would like to see any gallbladder calcifications which are not present, sir. And I would like to check for any pancreatic calcification which are not present, and there is no ascites as such.
Why were you looking at the gallbladder on CT scan?
Sir, I would like to see any calcifications, sir, because
which is better investigation for gallbladder, ultrasound or CT?
Ultrasound, sir.
Ultrasound did not show anything. Pancreas, yes.
Coming to arterial phase, this is an arterial phase showing lower lobes of lungs. Liver, there is a IHBR. There is dilatation of intrahepatic biliary radicals. I can see the confluence forming here, sir, followed by the dilated CBD, which can be traced. And there is an abrupt cutoff here, sir. I can see a mass around the CBD in the lower end here. And there is dilated gallbladder. I would like to see the pancreas, which appears to be normal. And there is a dilated pancreatic duct and double duct sign, sir. Coming to portal venous phase, sir. I also looked for.
You commented on a mass in the pancreas in the arterial phase. In which phase is a mass in the head of the pancreas best seen if it is pancreatic ductal adenocarcinoma?
Pancreatic parenchymal phase, sir.
No, it's portal venous phase. These masses are usually hypodense. In the arterial phase, you will see only if it is a neuroendocrine tumor. So the best phase to see a PDAC mass, pancreatic ductal adenocarcinoma mass, because most of them are hypodense, will be a portal venous phase.
You can see the.
Anything else which you should have commented in the arterial phase?
I also saw the relation of the tumor with the SMA, sir, which is far away from SMA, and also I was to see
will be important for you during the
arterial anomaly was there, sir.
So you must comment on that, the right hepatic artery, any aberration.
Yes, sir. Actually, left hepatic artery, common hepatic artery, right hepatic artery is arising at the celiac trunk, and there is separate origin of left hepatic artery.
Okay, it's okay. Go on to the
Yes.
portal venous vein.
I could see the portal vein, sir, forming, which is there is no contour irregularity. The confluence is formed, and there is no contour irregularity, sir, near the mass.
Show the area where the dilated CBD is getting blocked. So this is the CBD, then it becomes blocked, and you can see some enhancement in the wall. Next, go down. Go down. Yeah, see this enhancement? And in the next cut, what do you see on the right side? On the behind, posterior. Yeah, what is this? The hypodense.
This is the mass, sir.
That is the mass. So see how it is seen. And you can see that small pancreatic duct. It's probably not dilated, it's just prominent.
Yes, sir.
That, yes. Go little higher, go 1 or 2 cuts higher. Again, you can see that's the PD, that's the PD. This is the hypodense mass.
Yes, sir.
Yeah, that's the PD. And this is the hypodense irregular mass. Go up a little bit more. Now you see the CBD, and the CBD will get narrowed. And at the point where it is getting obliterated, you can see some enhancement.
Yes, sir.
Yes. Now that hypodense mass, if you see carefully, I'm not sure whether it is in the, now because we are going caudal to the CBD, we are going in the lower part of the head of pancreas and uncinate. So
Yes, sir.
is this a mass in the uncinate, or is it a node which is lying behind the pancreas? That we will have to see carefully. Looks like within the pancreas, because then you see pancreatic parenchyma around it.
There are no lymph nodes seen, sir.
And you didn't describe the liver. You should have said that there are no space occupying lesions in the liver, no ascites, and then you have to comment on the relationship with the vessels. Show us the vessels in the area of the mass.
Yes, sir. I would like to show SMA, sir.
Mhm.
This is celiac trunk, sir. This is SMA, sir, which is very far away from the tumor as such. Here the tumor is, and it is far away from the tumors.
Yeah, although here also you can see the mass. I agree with you. You can see the hypodense mass. Go
Yes.
little down. That's the pancreatic duct. That's the pancreatic duct. Yes, go down. Yeah, you can see the mass here, hypodense.
Yes, sir.
Mixed density actually.
Yes, sir. Coming to portal venous case, I would like to see the relation of the portal vein to the mass, sir. Here I see the confluence following down.
Depending on the location of the mass, which vein you think is more likely to be involved, portal vein or SMV?
Sir, it is the mass is just beside the assembly, sir.
Yeah, because it is in the lower part of the head, so it is more like it is below the formation of. See the formation of the portal vein, splenic vein, and SMV joining. You don't see mass here. You see only dilated CBD. Mass is caudal to that, so the vein which is likely to be involved is SMV. That is important because portal vein is easier to handle. SMV is more difficult to handle.
Yes, sir.
If it is involved. Yes. Go down, go to the area of the mass. So is the SMV involved?
No, sir.
You can see normal parenchyma between the hypodense mass and the SMV, isn't it?
Yes, sir.
So what is abutting the SMV is the normal pancreas, not the mass. Yes, here. See the hypodense mass?
Yes, sir.
So how do you decide that a vessel is involved or not on CT?
There should be a distinct fat plane between the vessel and the tumor. Then it is not involved. And the circumference of the vessel which is in contact with decides whether it is resectable or not.
What else?
And the contour irregularity is also seen, sir.
So it starts with presence or absence of fat plane, then the angle of contact, then alteration of shape, alteration of lumen, and thrombosis, and finally complete occlusion. These are various grades of involvement of any vessel in any tumor, whether it is SMV or portal vein or SMA here, or whether it is the aorta in relation to a CA esophagus. What's the radiologist's impression?
What is that sign called where contour abnormality is there, Sindhura?
When there is an alteration of shape or contour, what is it called? Teardrop sign.
Teardrop sign.
The
What do they say?
report says it is an ill-defined, small, heterogeneously enhancing soft tissue density mass of size 2 cross 2 cross 2 centimeter, seen in periampullary region with non-separate visualization of pancreatic head and uncinate process. The lesion is encasing and obliterating distal CBD, resulting in proximal dilatation of 13 mm and MPD of 5 mm with dilated IHBR. Mass closely abuts duodenum with indistinct fat planes, likely neoplastic, and gallbladder is distended and shows normal fluid density. Wall thickness is normal with no evidence of pericholecystic fluid seen. Liver appears enlarged 15.9 centimeter craniocaudal span, suggestive of hepatomegaly. Sir.
That's the complete report.
Yes, sir.
Are you happy with it?
SMA and portal vein could have been mentioned clearly. Sir.
Yeah, they haven't mentioned anything about the relationship of the mass with the vessels, which is the most important thing in pancreatic head mass. So you should say that this is an incomplete report. I would have liked to know about their opinion for involvement or otherwise of the vessels. So whenever you are given a report, you have to point out the deficiencies or the incompleteness of the report. Any other investigation was done?
No, sir. I would like to proceed with the management. Sir.
Thank you. Thank you very much.
Thank you, sir. Yeah. Thank you, Sindhura.